Good afternoon, everybody. I'm Dr. Pratik Tambe, Chairperson for the AMOG's Endocrinology Committee. A warm welcome to all the respected dignitaries and eminent faculty who are here for today's program. Today's theme is Key Issues in Obstetrics and Gynecology. We are privileged to have three fantastic stalwarts who incidentally have been past chairpersons of the Food, Drug and Medico-Surgical Equipment Committee here as chairpersons for today's event. But before we begin, I'd like to start by expressing my gratitude to our AMOG's president, Dr. Nandita Palshetkar. Madam is the current president of AMOG's, the immediate past president of FOXI. She's also been a president of IAG in the past, and very soon, next year, she'll be taking over as the president of ISAR as well. Thank you, ma'am, for your guidance and your blessings always. Next slide, please. I'd also like to express my gratitude to Dr. Arun Nayak, who's the secretary of AMOG's. Sir is a distinguished endoscopic surgeon and a fantastic academician in his own right. Thank you, sir, for always being there for us in all our academic endeavors. Next slide, please. At this juncture, I'd like to express my gratitude to the ICOG chairperson, Dr. Mandakini Meg, the secretary of ICOG, Dr. Parag Biniwale, for granting us the ICOG credit point for today's event, and also for the innumerable events which we've done over the past 1.5 years. Next slide, please. We are delighted to welcome our Vice President of AMOG's, Dr. Rajendra Singh Pardeshi. Sir is a fantastic academician and a medical college legend as far as teaching is concerned. He has won 6 times the Best Paper Prize at FOXI's AICOG conferences, presented over 27 papers in national and international congresses. He's been faculty at various international conferences as well, and we know him as somebody who is an ardent academician and promoter of youngsters. Thank you, sir, for always being there precisely on time at 2 o'clock for all of our events, including today. Thank you, sir, for being here. Next slide, please. It's my privilege to welcome my dear friend, Dr. Amey Purandare, consultant OB/GYN at several hospitals in South Mumbai. Now, recently, been elected as the second vice president of AMOG's. He's also served as the joint secretary of FOXI in 2019, chairperson, as I said, for the Food, Drug, Medico-Surgical Equipment Committee of FOXI in the past, assistant administrator for the FOXI Manyata project, and he will be leaving for a FOXI Manyata meeting very soon. But before that, we hope to have some important pearls of wisdom and academic key practice points from him during today's event. Next slide, please. We are delighted to have with us Dr. Vidya Thobi, an excellent academician, and she is the professor and head of the Department of OB/GYN at the Al Amin Medical College in Vijayapur, previously known as Bijapur, for those of you who are not aware. Chairperson for the Food, Drug, Medico-Surgical Equipment Committee, national corresponding editor of the FOXI journal, known as Jogi. She is the organizing chairperson for Kasoga in 2016, served Kasoga also as the treasurer, and several other distinguished academic positions. We wish her good health. She's recovering, and she's actually made time for us despite her ill health, and we're really happy to have her amongst us. We have 3 stalwart speakers here with us today. Dr. Shobha Gudi, who's the chair for the FOXI Family Welfare Committee, Dr. Rohan Palshetkar, who's the joint secretary of AMOG's, and Dr. Subhash Mallya, who's the chair for the FOXI Endoscopic Committee. Today's program promises to be a fantastic academic treat for all of us. So sit back, relax, enjoy your afternoon with us. And without any further ado, I will hand over to the chairpersons to conduct the further proceedings. Thank you very much.
Good afternoon, everybody. Today, I would like to invite Dr. Shobha Gude ma'am for her talk on implant. Dr. Shobha Gude ma'am, I think she doesn't need any introduction. We know her since a Bangalore society, and they had organized such a nice conference, AICOG. We couldn't forget her work in that also. But to say right person on right chair, and she is the right person heading the chair as chairperson of Family Welfare Committee. She was president, Bangalore Society, 2018, now chairperson, Family Welfare Committee, secretary, Bangalore Menopause Society, accessor, GY Project Lux, Board Member FPI, Peer Reviewer Jogi, elected GCM ICOG, Executive Member of Kasoga, Distinguished DNB Teacher, and her organizational work as Scientific Chair AISUJ, as I told you, Organization Secretary, IMS Con, then Scientific Chair, Triple O, Surakshit Naritwa. There are affiliation and many awards and publications on her name. I think she is the right person to address us on Implanon. Over to Dr. Shobha Gudi, ma'am. Thank you, ma'am, for addressing us.
Thank you, Dr. Pardesi. You have been a guide for so many of us who have become chairpersons after you, and your vice presidential year was actually so inspirational. Thank you so much for those kind words. And I think, always we look towards you for guidance. Dr. Tambe, Pratik, I must really thank you for giving me this opportunity, because any platform in AMOGS is such a privilege to come and speak to the august audience, to the members of AMOGS. It's a huge privilege for me. Also, I place on record my gratitude to Dr. Nandita Palshetkar. I have had the fortune of working with her when she was president, and I have known her for a very long time now. Dear Nandita, thank you so much. Thank you, Dr. Nayak. And I also thank the other two chairpersons, my dear friend Vidya, and of course, the bright boy, Ameya, who is kind of, climbing the ladder very high in AMOGS, and I wish him all the best. So this is the organogram under which I function, and I humbly accept the compliment that, though I would want it to be true, what Dr. Pardesi said, whether I am the right person for this post, because I myself get qualms and doubts at times. So this is the organogram under which I have functioned for the last 18 months. And I must thank Dr. Gandhi, Dr. Tank, and Dr. Ganatra for being ever so supportive in whatever I venture to do. Whether I succeeded much or not is another story, because family welfare is a very complex area to perform. Today I thought that there are so many learned people in AMOGS that general contraceptive methods which are already existing, they may not want more insights into that. So I requested Pratik that I must speak about implant, the novel device. And indeed, implant can today say that it is the new wonder, but in fact, this is a kind of rejuvenation, because we have had Norplant for several years in the past, and also other versions of Implanon in the past. So this is the current one, Implanon NXT, 68 milligram of etonorgestrel, a synthetic progestin. Well, when we look at the need for long-acting contraceptive methods, it is very tangible fact that if we have to walk towards or achieve anything for sustainable development goals, then female empowerment becomes of paramount importance, and gender equality which goes with it. And if contraception is provided to them without any gap of unmet need, I think it allows them to perform better, to better support their families. The economic productivity increases, and this goes hand in hand with educational attainment, and therefore it is very important that we educate our women and give them the appropriate choice of contraceptive methods. And increasing the basket of choice should be our prerogative. Unintended pregnancy can affect a woman's educational and career goals very, very hugely, as well as her children's health, and of course the social outcomes. When you look at the number of unintended pregnancies, it is so very obvious that more than 40% of pregnancies worldwide are unintended, and in India it is a little higher. It is close to 50%. As you can see, the low and middle income countries take the maximum burden of unintended pregnancies. Social and economic impact is very huge, which I have already spoken about. 2/3 of families started by teenage mothers are poor, and nearly 1 in 4 will depend on social welfare within 3 years of childbirth, are the data which come in from developed countries. But then Our country doesn't have this kind of concrete data, but yes, 66% of children born to teen parents earn a high school diploma. What I wanted to convey here is women who get married early, if they can put off their first child's birth, then it really goes a long way in protecting her from the ill effects of unintended pregnancy. Foxy goes a long way back. In 2010 itself, it endorsed the fact that contraceptive implants are actually a very promising, effective method, and that they should be available as an option for contraception to every woman who is at risk of unintended pregnancy. It does conform to all the requirements of contraception. It is accessible today, it is acceptable, it is affordable, because if you look at the protection which it gives for reliable contraception for 3 years, it's a simple OPD procedure. It is effective immediately, does not require an add-on, does not require the expenditure of additional lab tests, and of course it does not interfere with the sexual life of the woman, and the return of fertility is very prompt. And what goes along with this today, from this point of view of the service provider, is a high level of accountability, because follow-up also can be given to these women in very effective way over teleconsultation, because pandemic may not allow them to come frequently to the hospital. To answer the question how effective, it's almost as effective, in some context more effective than the sterilization procedure. It is 99% and more effective. And it is one unintended pregnancy in 2000 users in the first year of use is what we know about, and implants are 120 times more effective than injectables, several times more effective than other methods. What is the global feedback? There is a very high user satisfaction rate, high rate of continuation. MEC revisions have already happened to support implant use, and it is a very heartening fact to know that today implants can be provided to the woman before she goes home after delivery. And that is something wonderful. Implant can be inserted subdermally to a woman who has just now delivered with a MEC category 2. And that is good enough for us. If it overcomes the barriers to access modern contraceptive methods, yes or no? Of course it does, yes, because it is a one-time fit it and forget it option. This is the performance of countries across the world where it is very much present today. And on a very promising note, I can say that almost all neighbors of India, perhaps with the exception of Pakistan, and maybe to some extent Sri Lanka, where PPIUCD is more, implants have proven, even in Nepal, though it is not mentioned here, Nepal also endorsed, even Bangladesh endorses implant in a very huge way, and India is on its way. We got it introduced, approved by DCGI in 2019, and since then the Family Welfare Committee has been actively involved with the industry partner MSD and has been conducting regularly training sessions, and of late we have been conducting virtual training sessions. The currently available method, the device is radio opaque in nature, and it has already been time tested in 17 countries with clinical trials, and in 6 countries the radio opaque one has been, the previous non-radio opaque has a higher tenacity. It has been tested in 17 countries. This is how it looks, and in real life situation, this 4 centimeter long and 2 millimeter thick one device can have a perfect analogy to a matchstick. So we can tell the woman that it looks like a matchstick with a dedicated pre-loaded sterile applicator, requires some training to insert and remove, 99% effective, slight concern about interaction with enzyme inducers and in obese women, and I will come to that. It acts by ovulation inhibition. It is fantastic in its efficacy and also thickens the cervical mucus, and the concentrations required are reached almost within 24 hours, and they are sustainable throughout the 3 years of use. Of course, there is some change in bleeding pattern, and 1 in 5 women may report as frequent and prolonged bleeding, and some women may report as amenorrhea. But with good counseling, information about the benign nature of these problems, actually continuation rate should not get affected. It is good to note that some women do benefit who have been previously suffering from dysmenorrhea do benefit from pain. And this is the adverse reaction which has led to discontinuation. In a study of 942 women, the adverse events reported around 14%, and the other reasons have been bleeding, the irregularities, and planning pregnancy, etc. And that has led to a discontinuation rate maybe roughly of about 15% within 1 year. But that has since then changed now because of better follow-up and better support for follow-up care. This is again the list of adverse events, and you can note that there are symptoms written here which can actually may not be related to the drug. It could be coincidental, but about 5% of women totally can report sometimes headache or maybe some emotional instability or nausea or breast pain, and or some weight increase which may not be related. The complications of insertion and removal, and this can be brought down by very, very good training. Insertion or removal may cause some local bruising, slight irritation, pain or itching, but this is very rare. I have not found it so far. Fibrosis can occur if the insertion has been difficult or has been repeated. Some nerve might get touched and paresthesia might develop, but these are all rare. What is of concern are the post-marketing reports of migration and into the major vessels, and that is very rare, and off late with training, if the placement is subdermal, migration will not happen. Complications of insertion and removal to continue when it migrates to the vessels, it has to be localized, and it can be done with imaging techniques. So at any point of time during the use of implant, if it is not palpable, it is of utmost importance to make every effort to localize it. Can breastfeeding women use? Of course, they can use. Very small doses of the drug are secreted of no consequence. Some contraindications, just like COCs. Surprisingly, the indication contraindication profile matches more of the combined OC pill rather than of the injectable. And of course, if it is suspected pregnancy or an active disorder, thromboembolic disorder, or sex steroid sensitive malignancy, or liver problem, or undiagnosed AUB, or hypersensitivity to the device. Suppose a woman does fall pregnant, or she was already pregnant at the time of insertion, there is no evidence that it causes any teratogenicity, and there are no grounds for offering termination. Special warnings we have spoken about. To that, I should add situations of hypertension or insulin resistance like diabetes or dyslipidemia, and a skin condition called chloasma. All these situations we need to be a little more aware. I had said I will come to interactions, and this is one situation I must tell because we always discuss contraceptives in the context of the basket of choice, and when we speak about the basket, then the injectables score over the implants here, because injectables are seldom affected by anti-epileptic drugs or anti-HIV medication, which is happening with the implant. So in case women are on these medications transiently, then we need to wait for 28 days after their discontinuation. Since the medical profile, which just now we discussed, does not, conform to transient periods of treatment, I think women with long-term treatment with hepatic enzyme-inducing drugs, it is better to remove the implant and to prescribe a non-hormonal method. Counseling points, I feel that it may not be adequately discussed in a forum like this when there are two more speakers waiting. But then counseling, the better it is done, the better will be the continuation rate. So discussing the benefits, risks, and possible side effects, and still making her take up the procedure will be the high point of this requirement. One thing which we need to make extremely clear, apart from ruling out contraindications and counseling them about the side effects, especially of the bleeding patterns, is that there is absolutely no protection against STI or HIV. Definitely not, because the moment we say contraceptive, women should not mistake it for protection against STI, and they have to use a barrier contraception to achieve that. Insertion, we may not be able to go through the procedure. Very simple, and this is the position which is adopted. The non-dominant hand externally rotated and the hand near to the ear, and the point of insertion is on the surface of triceps muscle, much below the neurovascular bundle, which is exactly between the biceps and the triceps muscle. So this is 8 to 10 centimeter from the medial epicondyle, and under local anesthesia, just subdermally, the implant is placed. And she is strictly instructed that if at any point of time she cannot feel the implant, then she has to report immediately, and we have to make every effort to localize it with the help of a imaging technique. And if we have verified the presence of implant, till we have verified the presence of implant, she has to use a non-hormonal method, otherwise she may fall pregnant if the implant is not in place. And of course, a non-palpable implant has to be located, removed as soon as it is possible. Okay, so sorry, the slide is not moving, and oh, I'm sorry, the slide is not moving.
Double click. Do it. Double click, Shubha.
Yeah,
Double
I'm doing it.
That will
Very sorry.
go on that slide and double click.
I'm doing that. I'm not able to get the cursor.
You can just escape out.
I'll do that.
Step out.
I'll do that.
And
Yeah.
again, you can share.
Yeah, I'm doing that. Okay. I have pressed escape. It has not worked. Because I'm not able to. Okay. Should I share again?
Yes, ma'am.
Yeah. Sorry about that. Very sorry. Yeah. So can you see my screen now? But I am still lacking my cursor.
We can see your screen, Shobha.
Yeah, Vidya, but I'm
Directly
lacking
to
my
the
cursor.
slide. You can go directly to the next slide and hit slideshow from there.
Yeah, I'm doing that, but I'm not able to see the cursor. I'm very sorry for this. Okay. I had few more slides only left.
So you can go from your computer. No problem.
Yeah, but
Directly. No, just you can continue. Na?
Cursor, no? That is
how? I can.
Yes, you
but
can continue your talk.
I can continue, but the slide is not moving.
You can just hit F5.
Okay.
And use
What
your
should I do?
keyboard. Just hit F5.
F5. Just a moment. Together, na? Yeah. Nothing
Means
has
the
worked.
function key right at the top of the keyboard. F1 to
See,
F12.
I can see the highlight happening, but because I want to stop share now, and I can see the cursor moving on that, but I can't actually see the cursor.
Madam, I can stop share for you.
Yeah, please stop share. Yeah, you did that actually earlier. So let me, there is a problem in the PowerPoint. I think there are videos included, and that is the reason there is a problem.
Madam, if you could just do an Alt F4, the PowerPoint will close, then you can reopen the file again.
Okay,
Alt
what should I do?
F4.
F4, okay.
Alt F4.
Alt F4, one moment. Alt, this is Mac, so Alt I'm not getting. Alt is there, Shift is there.
Madam,
Alt
then you'll get all the things in the bottom right actually, if you are having
Hey, Alt mil gaya, Alt and
F4.
all three together, right? No, the cursor did not come back. It is just moving, but it is not showing itself. I'm very sorry. You go on to the next speaker, and I'll come back for some interaction in the last slides.
No worries, ma'am. You can continue your talk without the slides also. That's fine.
Shobha, you must have so many training sessions, no? You can speak like
Yes,
that only.
yes. You can
No, I will speak,
Implanon.
but it would have
I
been
know
nice
that
to have the last slide.
Implanon is to your heart, so you can speak without slides also. I know that.
Can I just say that I will kind of show the last few slides after Rohan's talk?
Yeah,
Is
Yes.
it okay? I will log
that
out
you
now
can
because-
show.
Yeah,
So,
I'll log out now. Thank you very much.
Thank you, Dr. Shobha. Actually, she has narrated she has covered all, more than 80-90% of this topic. and she had explained very nicely the need of long-term contraceptions, and this Implanon is a really accessible, affordable with simple OPD procedure, and it's for 3 years, and a return of fertility is immediate effect, higher rate of satisfaction is 90% effective. Means some contraindications are there and minimal side effects are there, but she had explained very nicely. Thank you, Shobha, for your presentation. Thank you so much.
Before we move on to the next speaker, I put on record my sincere gratitude and privilege to be sandwiched between Dr. Rajendra Singh Pardesi and Dr. Vidya Thobi. I followed Dr. Rajendra Singh Pardesi as chairperson of Food and Drug Committee. It was an honor to follow that, and I feel privileged that the committee was taken over after my tenure by none other than Dr. Vidya Thobi, ensuring that the benchmark that Dr. Pardesi raised the committee to, because he was the proud recipient of the Best Foxy Committee Award during his chairmanship of this committee. So I'm very happy that Dr. Vidya Thobi has continued the same hard work and the legacy that we had learned from Dr. Rajendra Singh Pardesi. Before Dr. Pardesi took over, the committee, even though it was headed by many a stalwart, was never considered as an important committee in Foxy. But he ensured that every aspect of this committee, food, drug, medical equipment, surgical equipment, is so essential and so important in the practice of modern day obstetrics and gynecology. And he motivated me to continue the presence of this committee in the board of control of Indian standards, where now Foxy has a permanent place in deciding which medicines, which equipment is to be authorized for standard approval. So I'm really privileged, and then I would now like to introduce the next speaker. Thank you, both of you, Dr. Pardesi and Dr. Vidya Thobi.
Thank you.
It gives me great pleasure to introduce the next speaker, Dr. Rohan Palshetkar. He is the head of unit of Bloom IVF at the D.Y. Patil Medical College and Hospital. He is the second joint secretary of AMOGS at present, joint treasurer of MAG, managing committee member of MSR and MOGS, associate professor at the D.Y. Patil School of Medicine, proud recipient of the Foxy Corion, Shanti Yadav, Kumud Tamaskar, and the late Praveen Mehta awards. Indeed, he is the most deserving person to get this award. For his various academic interests and his sincere service to the various organizations that he is a part of, the AOFOC, that is the Asia Oceania Federation of OBGYN, has conferred upon him the Young Gynecologist Award. He's also been the Foxy Yuva Orator in 2020 and the ISAR Yuva Orator in 2019. Dr. Rohan Palshetkar is working very hard for AMOGS for the last few years, and I'm very happy to see that he is serving AMOGS selflessly, and I hope that he continues the same in the years to come. Over to you, Dr. Rohan Palshetkar, as we hear from you about the current management of male infertility.
Thank you so much, sir. So it's always a privilege to be introduced by you. It's really amazing to have you and Pratik sir always mentoring me in Mumbai about how to go about to all the various organizations. In 2019, I must say that both of you have guided me through the F of Foxy, because that's the starting letter, and hopefully by the end of it, I should reach the I as well. And of course, Dr. Pardesi sir, I've worked under him also in Foxy 2019. Sir was the vice president, and I'm working under him in AMOGS as well. Vidya Thobi ma'am, Shobha Guri ma'am, it's always a pleasure to have you. And you can hear the passion of Shobha ma'am when she's talking about contraceptives, and you can feel the passion when she is talking about it, because you can understand it's not just the theory, it's about what she actually puts into it with all her heart. So thank you so much, Pratik sir, for giving me this opportunity to be a part of this webinar. I'm going to be talking about current management in fertility. Let me just please share my presentation. I hope it's visible. I'm just going to minimize the video. So I hope the screen is visible and I'm audible.
Yes.
Right?
Yes.
All right. Firstly, we're going to be talking about male fertility, and I'm going to be covering about all the parameters of male infertility. We're going to be talking about how to manage patients with low counts, with low motility, with low morphology, and even azoospermic patients as well. So if you look at it at the fertility point of view, we're looking at the female infertility, where we're looking about the HPOA axis as well as the uterine cavity. And of course, when we're looking at an infertile couple, this is something that rarely gets discussed, but needs to be understood that infertility is covering the couple, not the female or not the male. It has to be treating the couple. But today we're going to be talking mainly about male fertility. So when we're looking at male fertility, these are the three things that are basically looked at. One is your sperm count, whether it's normal or low, whether the morphology is normal or abnormal, and motility, if you have a normal progression motility or an abnormal motility. So what can be the basic causes of male infertility? Obviously, any injury, considering we're a highly sporting nation, the chances of injury to the groin area are high, especially while playing sports. Also, exposure to chemical or toxins. So it's important to ensure that during your history, you do find out what the profession of the male is. Use of any anabolic steroids, especially those who are going to the gym, if they have used any steroids for bodybuilding, any hormonal imbalances, or any congenital abnormalities as well. So when you look at a patient who comes in, the first thing what you need to do is physically examine. Begin with your basics. Start with an inspection. Check for the body habitus. Check for the hair distribution. Check for the presence of any gynecomastia. Check for any unicoid stature. Also, now check for any gender affirmation surgeries as well. Next, you need to inspect the genitalia. You look at the penile curvature, check for any hypospadiasis, any surgical scars on the scrotum or the pelvis. Then you need to examine the scrotal contents manually. Look at the size and consistency of the testes. Check for the epididymis. Check if there's any distension, any turbidity. If there is the presence of the vas deferens, presence of any varicocele. Check for, do a per-rectal examination to see if there's any prostatitis. You basically have to see that. Now, one of the most common investigations that every person would do for a fertility couple is a semen analysis. But now if your semen analysis comes abnormal, especially with the azoospermia or a very low sperm count, with the oligoasthenoteratospermia, do your endocrine evaluation, do your FSH, do your LH, do your testosterone, prolactin, do your estradiol levels, and even your thyroid profile. Also, in such situations, do a sonography. If you're suspecting anything on your physical examination, check for the testicular volume, check for the presence of any varicocele, presence of the vas, any abnormalities of the ejaculatory duct or seminal vesicles. Now, antioxidants are going to play a bit of a role because, as I show you through my slides, 40% of patients with male infertility are going to have a reactive oxygen species which affect their motility. Now, what is oxidative stress? Basically, it's resulting from the imbalance between your pro-oxidants and your body's scavenging abilities. So if the equilibrium is not maintained, you're going to have more oxidative stress on the body, and this can affect your sperm counts as well. Now, you can see that in the females, it can affect your oocyte maturation, your ovulation, your fertilization, your embryo development, and even the pregnancy itself. In males, it's basically involved in the tortuous journey of the sperms from spermatogenesis till fertilizations. Now, you can see the various things that can increase the reactive oxygen species. And this increase in the oxidative stress can cause an injury to the cell, the mitochondria, and as well as the DNA as well. And this can result in increased sperm count, decreased sperm count, decreased motility, and increase in the abnormal sperms there. So how does it work? So basically, due to the oxidative stress, your inhibin B levels can rise and there's a hormonal disruption. This can cause a suppression of spermatogenesis. Besides this, the oxidative stress can lead to cell damage, especially the membranes, and as well as the DNA damage as well, leading to male fertility. As I said, elevated levels of reactive oxygen species have been found in the semen in more than 40% of infertile males. So this paper, which was published, basically, it's a small study, but this was something that showed that 23 patients with unexplained infertility, basically that there's no possible reason for why they're not fertile. They saw that level of antioxidants in patients with unexplained infertility was significantly lower than those in fertility patients. Levels of MDA, lipid peroxidation end product in peritoneal fluid were higher in patients with unexplained infertility. So reactive oxygen species induced by lipid peroxidation could have a role in unexplained infertility. Wang et al. Also showed that levels of ROS in the peritoneal fluid were significantly higher. And Agarwal et al. Showed that localized oxidative stress can have a role in etiology of unexplained infertility as well. So basically what it's showing that systematic and placental oxidative stress now in recurrent pregnancy loss also has a role. Recurrent pregnancy loss can be quite mentally traumatic to a lot of patients. And this high ROS can basically lead to RPL because of vascular endothelial damage, oxidative damage to the placenta, impaired placental vascularization, and immune malfunction as well. So now when I look at my ART setting, where is this oxidative stress actually playing a role? One, it's affecting the sperms. It's causing oxidative stress, causing my DNA damage and apoptosis as well. My oocytes is going to lead to poor quality oocytes. It's going to lead to abnormal fertilization. And therefore, I'm going to get poor quality embryos as well. But since I'm talking about the sperm, I'm going to see how the sperms actually, antioxidants actually help in the sperm morphology, motility, and count as well. So you have astaxanthin, which is an ACE antioxidant. You have your CoQ10, which is your bioenergetic antioxidant. And you have the other antioxidants which play a different role. I'm going to mainly concentrate on astaxanthin and CoQ10 and how it has an effect. Now, this study, which was published, basically talked about astaxanthin for male infertility. This was a double-blinded randomized control trial. It was 30 infertile men which were included in the study. The study group received 16 milligrams of astaxanthin for 3 months, and results showed a decreased level of the reactive oxygen species as well as inhibin B, and the motility was improved in the study group as well. Now let's look at coenzyme Q and male infertility. This was a meta-analysis. Basically, it showed 3 trials, and it showed that in giving CoQ10 improved the parameters in sperm concentration and sperm motility. However, there was no data regarding the live birth rates. This was another paper which was published, which basically showed supplementation of CoQ10, and this meta-analysis showed marked improvement in the concentration, that's the count, as well as the motility as well. Then you had your L-carnitine combined with coenzyme Q10. Basically, what they showed that the combination was better, showed improved sperm parameters as compared to the other groups, and the clinical pregnancy rate was higher as well. So basically, your antioxidants in infertility shows reduced lipid peroxidation and maintains the cell membrane integrity. It reduces the DNA oxidative damage and reduces the mitochondrial dysfunction. And this altogether is going to improve your sperm count, sperm morphology, and the sperm motility as well. Now let's come to azoospermia. We know that the 2021 World Cup is coming, but this is not the real reason why there would be azoospermia. Now, azoospermia is going to be present in about 1 to 3% of all men and in 10 to 15% of all infertile men. Men coming for treatment could also be due to post-chemo or malignancy, and you will probably get a better understanding of what the cause of azoospermia is through your hormonal assay, your genetics, and ultrasound. Now, with the introduction of ICSI, the chances of it said that male fertility could possibly be gone in the future. And with azoospermic patients with better microsurgical techniques, sperm retrieval rates are also improved. So how do you diagnose it? That there's no live or dead or immature sperm seen at least in 2 consecutive samples taken at an interval of at least 4 to 6 weeks. Your absence should be confirmed in the pellet after centrifuging. So now basically you can see that there probably could be no sperms produced in the testes. There could not be present enough in the ejaculate, or there could possibly be an obstruction. Now let's go for a protocol, what I would do for getting an easy diagnosis. So as I said at the beginning of my talk, when a patient comes with of azoospermia, just do a quick examination of the testes. If you have a small testes, you have a peanut-sized testes, you could just basically think of going for artificial insemination, donor, or adoption. Of course, now there are protocols, which say that you could think of microtessay, but in most cases, in majority of the cases rather, you'll be thinking of either a donor insemination, or if they want to go directly for adoption. If you have normal or low volume testes, do an FSH level. If your FSH levels are low, it's probably hypogonadotropic. If 3 to 7, obstructive, and more than 8 is hypertesticular. So less than 1%, you're actually going to get a hypo situation. Majority of the cases are going to be hypergonadotrophic, hypogonadism with a testicular issue. And then you're going to have post-testicular, that's normogonadotropic and normogonadism. So now when I look at hypo, this is when your FSH levels are less than 2. This is where your FSH levels would be very low, and your testosterone levels would also be low. This can be seen in congenital cases as well as acquired or secondary, where there's infection, trauma, tumor, or surgery of the testes. With congenital cases, the prognosis value is slightly variable, but it needs to be decided dependent on that. In acquired or secondary, your prognosis is good. The definitive treatment is gonadotropins. You can give FSH and you can give HMG, and that can improve the levels which can produce sperms. This is the only medical treated condition in azoospermia. You probably have to give long-term HMG or even HCG in these patients. Now, normo, that's basically your obstructive azoospermia. This could be congenital or acquired. Acquired, we obviously know. If it's congenital, you have to see whether it's proximal to the seminal vesicle entry, whether it's retetestes, vas, or epididymitis. Volume is generally more than 1 ml. Alkaline and fructose would be present in your semen analysis. You look at the distal to see if there's any congenital absence of the vas deferens, ejaculatory duct. If there's a low volume, and acidic and fructose would be absent. Now, your treatment for this is very easy. Either you can do an anastomosis, which is rarely done because most of these patients would end up going for an ICSI cycle. You can do a transurethral resection of the prostate and an ejaculatory duct obstruction. If there's infections, they tends to have multiple blockage, so correction's difficult. So in these situations, you can actually consider a TISA, a PISA, or even a microtessay in certain situations. If there is a congenital absence of vas deferens, you have to do the CFTR gene to just ensure that there is no cystic fibrosis, and you need to counsel if that's present to the patient that it can be passed on to the child as well. Especially with obstructive azoospermia, you get the sperms in 95% of the cases by one of the various methods, and it has a better take-home baby rate as well. Now, here in hypertesticular and non-obstructive azoospermia, here you have a compromised testicular function. There is probably complete failure of testes. You have your various etiologies. Currently, there's no medical treatment, nor the surgical treatment. You can think of maybe a microtessy, but a testicular sperm extraction and microtessy can be considered. But how do you select these cases is quite a challenge. Most of the times you would actually go in for a donor insemination, or maybe they might consider adoption. As you can see in prognostic sperm retrievals, you have in 50% success rates. Fertilization and implantation rates are poor, abortion rates are high, and there's high chances of transfer of abnormal genetic material, especially if there is in non-obstructive azoospermia. Also, what you have to look for is something known as Y chromosome microdeletion. So there are 3 types. You have your A, B, and C. Generally, with A and B, you're not going to get any sperms at all. In C, there's a sperm retrieval rate of almost 70%. But one thing that needs to be counseled to the couple, that the child born, if a male, will also probably have azoospermia, and they should be testing the child for his semen analysis as well. Obviously, I can't discuss too much in detail about this because I think I'm overshooting my time already. You have your various procedures like TISA, open to say, but now with the advent of micro TSA, I think the chances of getting your sperm retrieval have improved drastically, and you get so much better chances of conceiving. So when you look at the reproductive potential of obstructive versus non-obstructive, you can see that in obstructive azoospermia, your sperm retrieval rates are better, your fertilization rates are better, and your live birth rates are also better in the obstructive azoospermia because your testicular function is present. So to conclude my talk, diagnosis and management is very easy with the basic examination and endocrinological evaluation. In abnormal sperm parameters, especially with oligo, astheno, and teratozoospermia, antioxidants do seem to play a role in improving sperm count, motility, and morphology. In hypo is the only place where medical treatment would be available. In obstructive azoospermia, you have a very good sperm retrieval rate and your results are also good with ART, especially if there's no other female factor. In non-obstructive azoospermia, you have the recent techniques of micro-TSA where you have the best results of sperm retrieval. However, major challenges basically giving a prognostic value for the procedure. Reproductive outcomes are definitely inferior to obstructive azoospermia. So thank you so much for this opportunity to speak about male infertility. And thank you, Pratik sir, for giving me this opportunity to be a part of your webinar as well. Thank you.
Thank you so much, Rohan, for so very, very precisely and correctly discussing this challenging topic of male infertility, because very often our focus is mainly concentrated on the female factor, but the male factor is equally, if not more challenging to treat at times. And you have very correctly shown how we can manage, what we need to counsel, and what we need to explain to the couple as far as their offspring is also concerned, keeping in mind the implications of the male factor. So thank you so much. Thank you, Pratik, for inviting me to chair this session in the presence of Dr. Pardesi and Dr. Thobi. I will have to take your leave, as I told you, because I have to go for an important Manyata meeting. So over to the next chairperson for the next talk. Rohan, once again, well done, and thank you so much.
Thank you, sir, and sir, congratulations to you for being
elected. Thank you, Rohan.
Thank you, sir.
It was really a nice presentation. Thank you so much. And Ame, congratulations. I think Ame should give treat, but he is not giving. This is
party baki hai, sir.
Party baki hai. He is not giving party at all. What to do? We have to decide in our general body meeting. Okay.
Yes. Virtual party now.
So see, this is because I have to complain to Rohan. Rohan is joint secretary. Then he will inform to president.
Has to go through
proper channel. This is proper channel.
Yes, sir. Definitely, sir.
Okay. Over to next chairperson, Dr. Vidya.
Yeah. Thank you, Amox, Dr. Nandita Palshetkar, Dr. Arun Naik, and the most academic and most, what I must say is, there is no word to describe Dr. Pratik Tambe's enthusiasm. Every week I must see Dr. Pratik's one flyer at least on any of the groups. So that is Dr. Pratik Tambe. Not only on the virtual, but I have seen him working as AMOGS, not only AMOGS, in Foxy Endocrinology Committee. So many things he did, and he did visit Bijapur once, and I have learnt a lot from Dr. Pratik Tambe. Thank you, Dr. Pratik, for calling me to this platform again. I would love to introduce Dr. Subhash Malya, the youngest chairperson of Endoscopy Committee of Foxy, elect. And at present, he is practicing gynecology and minimal access surgery in Calicut. And he's a zonal coordinator to Foxy, President 2020, Managing Committee member of IAG, South Zone Coordinator of Foxy Endoscopy Committee as well, member of Foxy Endoscopic Committee since 2016, Charter Secretary, Kerala chapter of IAG, Secretary of Calicut OB/GYN Society, Medical Legal Counselor, and Executive Member of IMA Calicut, and he has won many prizes in the paper presentation in various conferences. And he's been as an invited operative faculty in various workshops all over India. He's given more than 500 lectures all over India, and he has won Best Video Presentation at Advances Trivandrum in 2012, way back. Second prize in a poster presentation in South Zone, Foxy, Madurai. So he is talking about endosuturing, how to simplify. We all know endoscopic surgery is speedily being a well-known option for the traditional procedure. There are various tips and tricks of various surgeons, and minimal access surgery has crossed mainly the hurdles of the illumination, camera system, and multiple types of stapling have come up, clippings, and energy-induced various hemostatic devices as well. So let us listen from Dr. Subhash the various tips and tricks and the simplified procedures for his endosuturing in the laparoscopic surgery. I take this opportunity to again thank Dr. Rajendra Singh Pardesi as well as Dr. Ameya Purandare for guiding me in my tenure of 3 years as a Food, Drugs and Medico-Surgical Equipment Committee, FOXY. And I always thank them for guiding and taking this committee forward. Thank you again. Thank you very much. Over to Dr. Subhash.
Thank you very much, Vidya Madam, for those kind words. At the outset, let me thank the MO Nanta Madam and Secretary Dr. Arun Naik sir, and also Dr. Rajendra Pardesi sir, Amay Purandare sir, Pratik Tambe sir for this organizing this wonderful webinar. Sir, I have some internet issues, sir, because it's raining very badly here. So if at all I miss, sir, please let me know, sir, because what happens is I'm having my very unstable. I have 2 Wi-Fi here, but then it's raining here, sir. So probably we may not be able to hear me, sir. Right. Right. The topic for today is endoscopic suturing, which is simplified. Bring warm greetings from Calicut. The question I quite often ask is, stitching time says 9 what? So right now, the definition is being, the suturing is defined as any surgical step which is intended to approximate the edges of the tissues that is discontinuous with the anatomical plane. So that's what we are planning to do here. The big question here is, suturing is an age-old technique. So why are we talking about suturing today? Is it really worth talking about it? Is the question now. The answer to that being, now this is the era now when where we have these people who are and then we have quick stop sticks. So it's like you have to get over and the crisis, and you have to come of age. So the world is evolving. We had the open surgery, then we had the laparoscopy, and now we have the robotic surgeries also. So why don't many people do lap suturing? The good answer to that would be a lack of confidence. It is time consuming. Definitely, it's very time consuming. The longer training curve, the curve is definitely more compared to open suturing when you can master it very easily, and also the poor ergonomics. And of course, these are the factors which hinder trouble. Improper techniques of knotting. 2D laparoscopy, there is always a problem with the loss of depth perception and the difficult eye-hand coordination that is always seen. So how is the laparoscopic suturing different? As I said, we have a 2D vision, we have depth perception problem, we have eye-hand coordination, we have a straight instrument, and the instrument usually open at a long from the body. So these are the factors which will actually trouble us in the suturing aspect. The significance of this, this is a roadblock. Suturing is the roadblock for many professionals to perform laparoscopic surgeries, more so the advanced laparoscopic surgeries. So I think it's proficient. If we are proficient enough in our suturing skills, definitely we can go and do all the advanced laparoscopic procedures. One of the major factors that I see is, the patient is here, the technology is also there, the surgeon is there, but unfortunately, the biggest problem or the hurdle that we find out is the surgeon's mindset. Now, if you're able to come out of this mindset that I would be able to suture, I would not have any problem with suturing, I think that's the important aspect which I would like to go through this study. Now, most surgeons hesitate to adapt to lap surgeries as it is difficult. Now we have the types of suturing. We have the ipsilateral suturing, we have the quadrilateral suturing. Again, we have the knotting, which is the extracorporeal knotting, and the intracorporeal. For the benefit of audience here and for the simplicity, I would be going more for the ipsilateral suturing and also for the intracorporeal knotting. Extracorporeal, I think for most of the lab gynetics, we don't usually use unless it's a surgical aspect. Now, the instruments that we need is definitely the basic core of this. We need a needle holder, which could be a straight handle or a curved handle. And we need a grasping forceps to pick up the tissue from that area. And we have an assisted needle holder, not much used nowadays. Now, being a training institute, what we have seen is we have a lot of shortcomings of this training. That's why we made a standard protocol to teach suturing in defined pole positions. Also, we are the proponents of an ipsilateral suturing technique. Many may not agree with me, but then I'm a proponent of the ipsilateral suturing technique. Now, nothing is controversial for that matter. Now, laparoscopic suturing, as I said, we know about the instruments that are required for this. Needle holders, I won't go into the depth of it. I will come down. This is what we normally see. You can see over here, we have the straight needle holder, we have the curved needle holder, we have the self-righteous one over here, and the claw. Okay. More often than not, what we normally use is the curved needle. Okay, we can use the straight suture, but that's only for when you have to retract the momentum or other aspect. But otherwise, basically, what we normally use is a curved needle. And the basic amount of suturing that we require is at least 15 centimeters for a intracorporeal suturing, but whereas for an extracorporeal, we may require about 90 centimeters. Now, I wouldn't go into the depth of it. I wouldn't go much into the theory of it. I would be more interested in showing that. This is called as the azimuth angle, which we normally use when you have a suturing. That's about 30 to 45 degrees, and the manipulation angle that we use is about 60 to 90 degrees. Now, all this said and done, once you're proficient, it's not a problem for this. But the critical step that we know first is the introduction of needle. Even before we learn suturing, we have to know how to insert a needle. Then you grasp the needle, tissue penetration, and knotting. I will be going into the depth of all of these with videos for this. Now, we have two methods of needle entry where we have a direct trocar entry and we have a backloaded one. More often than that, what we do is a direct trocar entry. And if you want to, this is how we do this. You can see here we load the needle over here. This is a 5mm scope over here, 5mm needle holder over here. You can see here we insert it. We have a good length of the needle over here, and then this is what we normally do. The full volume, she would always do the same way. You make it into a small one, put it across over here, load it into that. Now this is actually a 30 mm curved needle over here. Okay, this will not be backhanded into the, and that's how you insert with the needle. Again, I'll come down to that, the other video also. Now, coming on to the next aspect. This is now a similar one where we have made the needle slightly straightened. You can see here the needle is slightly straightened over here. It's not the normal, it's a normal 30 mm needle only, but then again I've curved it a bit. Okay, you go inside into that, it's a 10 mm scope. The earlier was a 5, the same method where you actually roll it down and keep it. You hold the tip of the, never hold the needle when you insert, never hold the needle, rather you hold the thread. Okay, you always hold the thread for it. Now this is straight needle, as you can see this will be loaded inside. You can see here, when you pull it, you can see how well it goes inside. So basically, you're not exposing. You can go through the port. Even for 10 mm port with the 5 mm scope, you can also do that. Okay. Now this is how you insert. Once you insert, you can see here you have held the thread here. You can see here important aspect. You've held the thread here, and you have actually put the needle inside. Okay, so this is what is the normal picture over here. Okay, so always you hold the needle, hold the thread, and push the thread inside. You don't hold the thread very far away from the needle. You can see over here. Okay, and then you insert your trocar inside. Now this is the setting of the needle. I always call it the ABC of it. A is you hold the thread, which is about 2 centimeters from this wedge when you want to manipulate it. B is where you hold the needle. That's about 1/3 of that, and this wedge is about 1/3 from the needle. From this suture. Is this? It's very easy to be said, but in practicality, it's very difficult. I hope all of us would maintain this, but I'm sure 95% of us wouldn't be maintaining this. I'm sure about that. I'm not being critical over here, but then unfortunately, most of us are on different postures. Now, this is the best. When it comes down to theory, this is the best one. Always try to, at least if not anything, try to keep two things. Try to keep your neck. Don't make it too high up, or too low down. As it is straight one is your leg, is your eye. Second is definitely the length. If you keep the table too high, it will be a lot of problem with the shoulders. So it's always better, the lower the table, so that the suturing is easy and the load on your shoulders is very less. Okay. Triangulation, straight line principle, gaze down, monitor where all are excellent. They are very good, But practicality, as I keep saying, it's not that easy. Now, insertion of the needle, I did show about that. Now, again, I have shown the same thing here. As you can see over here, same thing. I have just shown it once again. Yeah, you can see here the thread is over here. I'm sorry for that. Now, after you insert the needle, you have to hold the needle. And so you have to, before you do the suturing, you have to hold the needle. As you can see, it's always held at the junction of 1/3 and 2/3 of it with a concavity facing upwards. Smile on the shiny part. Now, this is very important. Laparoscopic curtsy, as it is called as, you do not pull the needle, rather you push the tissue. When you take a suture, always through the wall or through the fibroid, you always push the tissue. Do not even hold the needle because the needle tip will get bent, it will get damaged. So this is called as a laparoscopic curtsy. So remember this aspect, do not pull the needle, rather push the tissue, right? And the grasping the needle, as I said, grasp at the sweet spot. Okay. Now, this is actually not my video. This I've taken from somebody else. The left side of the video, you can see here. You can see here. You have held it at the sweet spot over here. Professional way of doing it. Now, many of us were finding it very difficult with that. You can see again over here. You hold the needle at the sweet spot. You can see how you manipulate the needle with the thread, and you go and take the suture. When it comes down to the real body, you can see over here. This is how we normally do here. You can see here the difference between a real nice video and a real video. You can see, just come back to this. You can see that you grasp the thread, as I said, hold the needle over there, and you don't hold it tight. You either hold it a little bit slow and then you rotate with the thread, and that is how it would sit in a proper position. Okay. Now, after this suture insert, you have to remove it, also very important. You can take out through the tendon port by not mounting the needle, but again, the same way you can also straighten it. Now, removal of the needle, as you can see over here, this is how mounting is done. Now, in real body, how you do, you can see over here. Okay, you hold it, you can see here, you hold it at the tip. You don't hold at the needle, then you channel out, you railroad your that's how you do. We have seen how do you put the needle, we have seen how do we insert the needle, we have seen how do we remove the needle. Now let's come to the most important aspect, how to do a suturing. Now, port precedence is very, very important. Ipsilateral suturing and the contralateral suturing, we all know. This is what we normally do with it. So the principle of suturing is angle between the upper arm and the forearm should be more than 90 degrees. So always maintain an obtuse angle in this aspect. No trunk movement. As Dr. Kuntambekar, who has taught me, always says, the movement should only be at the wrist joint. There should not be any movement in the knee joint. in the elbow joint. It's always in the wrist joint. The arms must be relaxed and elbows below side the trunk and below the shoulders. Now the surgeon's line of vision should pass through the surgeon's hand. It's your hand. It should be vision should be there. And the table height is at the level from umbilicus, so your comfort zones are maintained. Now, ipsilateral is where I'm going to give. It's a better ergonomics. Assistant is not required, and it's one-sided. Okay. Now, the advantages that I say would be a lesser fatigue, and it mimics the open surgery how you do. As I keep saying very often, from day one of my lab training, I keep saying, and I keep hearing this. Laparoscopic surgery is nothing but an extension of your open surgery. So whatever procedure you're doing in open surgery, the same thing is replicated in laparoscopic surgery more often than not. So that is why, not always, you mimic so ipsilateral surgery is more mimicking your normal open surgery. It is more useful in surgeries like myomectomy, where an odd number of sutures should be taken for that. Now this is now the basic suturing or the basic aspect is here. You can see here, that's how you knot it down. Okay, you hold and always, as I keep saying, always go behind the tip. You hold the tip for suturing, that helps you out. This is the backhand suturing. You can see over here. It's an easier aspect of this. Now this is the dangling needle technique, where you hold the needle in the sweet spot, but again you grasp. This is how you do it. You can see here the dangling. You don't really, I will go back again. You hold it the same. You can hold the thread here, and you're manipulating the needle. Understand that you're not supposed to hold the needle very tight because it doesn't turn as you would like to. Okay, you can see it. If you feel that the place where you held is not correct, this is how you use the thread. See for the angulation. Suppose you want to go at 45 degree, you want to go 90 degree, that's how you turn. So always do not hold the needle tightly, hold with a little bit of grip, a little bit of jaw open, and that's how you manipulate this. I assume it's very, very clear. Do not hold it very tight. Always keep a gap in between the needle, and that's how you manipulate it. Now, if it's an auto-rotating, well and good. If not, that's how you manipulate that. Okay, you can see the ease and comfort of the direction also, right? So that's all. Now, coming down to the next aspect, that would be again over here. You can see here, this is a curved needle. Whereas this is an auto-rotating one. All you need to do is you allow the needle to lie on the omentum, and that's it. So it's an auto-rotating one. It's very easy to use. It's a very nice one. But again, this actually is not a substitute for your that. It's only to make your life comfortable. Okay, you can see here. I would go back again. You allow the needle down on your omentum. You can see the left hand, the claw one. Whereas now what I'm inserting is an auto-rotating one. You fold the omentum, and then you can see here, that's it. So you get in a good position. Auto-rotating one, it's a good position to use, and you can go ahead with suturing. But the only problem with an auto-rotating one is the edges will be sharp, so be careful with the thread. So the thread may actually get cut. More so in a barb suture, the thread may get cut. You know, I've had a couple of instances, so I always am very wary of using an auto-rotating one when I'm using a barb for the thread's sake. Now, how you take a suture and form a loop? This is how the C loop is formed. You can see here, this is how the C loop is formed. You can see here the C over here. Okay, the C is over here, and that's it. It's a good one. Okay, you keep your left hand steady. Use your left hand. You can see here, you're taking a loop with the left hand, and then as I keep saying, always go and hold the tip. Always go and hold the tip of it, right? And then you pull down the needle. You pull down the needle. Slide it across over here. That's very, very important. Using a braided material, always slide it across. Don't be in a hurry to pull it, and have a knot. You'll be more often than it will be so. So always slide it across, and that's how you take a good loop. If you have a double knot or a square knot, that's always good. Right? It will always stay in place. Always try to take a double knot and not just a single knot, because more often than not, it doesn't stay in place. Okay. Now, coming on to the next one. Again, this is the left hand dominant. This is just for the sake of it. You can see the left hand dominant over here. And over here, you can see it's the right hand which is dominant over here. So if you're a right hander or like anyone, you have to be proficient in both. Okay. As a laparoscopic surgeon, I always believe your left hand, if you're a right hander also, your left hand is more important than your right hand. Okay. Right. So that's how the double technique over here. Now, in real life, now it's a very different thing. You can see here, this is actually a posterior suture over here. You can see the angle. It's not actually 90 degree. The angle is being taken up at around almost more than 135 degrees over here. Okay. So you can see here, that's how you take that suture over here. You can see it's not an easy suture. You can see how your wrist joint is moving. Okay, and see the difficulty. It's like a backhand. Like the backhand suture way of taking. Okay, right. Similar. Now again over here, this is how I keep saying what we showed. This is the dominant right hand, and this is the dominant left hand. Okay, now you can steady. Left hand is steady. You make a C. Go close to the thread. Go and hold the thread. Okay, this is the case of sacrocolpopexy, sacrocervicopexy. You can see over here a lot of sutures, and you can see the mesh over here. It's very important. I would like to stress upon. You can just see the direction in which you go is very important. You can see here. You can see I am going towards the bladder and I'm pulling it over there. The reason for that being your suturing skills alone are not important. Be very careful about this. This is a video which is from YouTube. This is not my video. You can see here. We've taken a wonderful stitch over here. The surgeon has taken a wonderful stitch over here. And there it is. Right? So that is it. So very, very careful as to where your needle goes and the direction of the needle that goes. Okay. Now this is again an ipsilateral suturing where post and ovarian cystectomy, the raw surface is very big. You can see here, you can take a figure of 8 stitch. Okay. You take a figure of 8 stitch over here. Okay. Hold it, pull it close. You can see the thread. Okay, always show. Keep the tip at your direction. Keep it across over here, and then you take it out. You can see this is the left hand dominant. Okay, going around. Always go and hold the tip, and then this is an easy one to slide, but ideally to slide is better. Now it's very important to get your direction also correct, or else the knot will get slipped. That's how it is. And you slide it across, and then take a stitch over here. Okay, so that's how It is, of course, it needs a lots and lots of practice. As I keep saying, it is not. It takes about almost 4 to 5 years. Not everybody are as skilled. You can see the other way around also, where you can see the right hand being taken with the needle. Be always very careful. I showed the previous video. You can see the needle over here. Put down the needle. Put down the needle always. Yeah, put down the needle always and try and hold the thread, because we don't want to do the same mistakes which I showed in the previous video. Okay. Now, ipsilateral suturing, as I keep saying, is the easier one. Okay. You can see here, this is with the white over here. You take the sutures. Okay, you can take the sutures. You can take it across. Okay. You can take straight. Always, it's very important, the initial one. And again, here you use a needle and then you suture it across. Now, contralateral is actually an ideal triangulation, but poor ergonomics and assistance may not be required for this. Again, the advantage is easier suturing, but the disadvantage would be more fatigue. You always obstruct the assistant in the camera because your hands are going across to the other side and the elbows are always over the shoulders. So your fatigue and the shoulder pain would be more in these cases. Okay. Now coming into the video of contralateral suturing, you can see over here. It's also very easy over here. You can see here the needle being taken. Okay. And then you just slide it across, put down the gloss, slide it across, pull it, make it the square knot, and then you pull it in place. So that's how the contralateral suturing would be. Okay, you can see here the similar one again over here. As I keep saying, do not hold the tip of the needle as much as possible. Always push the tissue as much as possible, as we call as the laparoscopic curtsy in these cases. Now, preferences. Ipsilateral suturing is ideal for ligating uterine and wall closure, for myomectomies, tuboplasties, and also repair of the viscera. Okay. Now, suture material, you want to use a vital, you can use a monofilament, anything is fine as long as you are comfortable with it. Of course, with the monofilament, it's actually very difficult to have knotting, but the tensile strength is very good with the monofilament. Okay. Now, barb sutures, as we all know, has come up a big way. It's revolutionized the era of suturing. It's made our life very easy. And I believe lots and lots of days, the cup days and everything has come down very much. I have a very good personal experience of almost about 3,000 cases where I have a very good thing with barb sutures. And I've been using barb for almost 11 years now, 10 years now. And I've been very happy with my results over this. Of course, there are a lot of controversy in the world, but I personally feel that we do not have as much controversy as maybe one or two small bowel obstructions which has been said in literature. Now, the most important aspect of this is the myomectomy suturing. The importance of myomectomy suturing, because more often than not, what is more required is we need all the suturing for myomectomy. For a gynec surgery, this is more important. So the importance is the obliteration of dead space. You can use a white or a barb sutures. You have to exclude the endometrium as much as possible. And baseball stitch is always better so that you expose less amount of the suture material to the surface. Okay. Now you can see over here, this is actually a large barb suture. It's about 13 to 30 centimeters, 36 to 36. Okay. Now you can see over here, importance is the obliteration of dead space. We're taking the suture, we're obliterating the dead space. That's the first layer over here, what we're doing. Okay. And then in the end, you can see here, this is how the baseball, you do not expose inside out and outside in, so that you expose a very little amount of the suture material of the opposite. The special conditions is when you have tube moving structures like tubotubular anastomosis in cases of recanalization, and also neurotosigmoid anastomosis. This is more for the surgical aspects. Okay. Now, could robotic suturing be the answer of any of all our problems? Let's wait and see what happens. Now, the advantages here is it helps to bridge the gap between the laparotomy and laparoscopy. Improved dexterity. Suturing is very easy in it. There is a tremor filtration, so better. It's always better for that. It's a three-dimensional view also, giving us a better advantage. And the intraabdominal circulation of laparoscopic instruments also is helpful. So it doesn't mind if the surgeon has spotted this by the previous day. His hands are not a tremor, so it's going to be easier one. It's steady and even tempered in case of. Now for learning, as I said, endotrainers, wet lab, animal suturing, cadaveric lab, and assisting live surgeries are the room. But all said and done, of course, you have to spend a lot of time on your endotrainers. But again, on the body, it's a very different experience. You can have a lot, you can spend hundreds of hours on endotrainers, but I think even 1 hour on the body is a very different thing. But that doesn't mean that you have to use even body as, where you learn. No, definitely not. I'm not going to say that. But my point is, you put one suture on the body, it makes a hell lot of difference for your confidence levels. Box trainers can be done to help at simulators also. Now, endo stitch is a new one which has come up. It's a plus a button and you place a knot. It's an advantage they're less time and easy to learn. Now, of course, it's a mechanical assisted suture device, and a pre-tied provides, the significant time saving to surgeons regardless of their experience. And less experienced surgeons and surgeons trained also can be useful. So, suturing, which is something which was thought to be difficult, with this laparoscopy has been simplified, and of course, hence it is possible for all to master it, is what I would like to say this. Okay, so now we have, chopsticks, or whether you buy the hand, it should be easy for all of us. Okay, so always aim high in life is what I would always say. Thank you very much, Pratik sir. Thank you very much, Vidya madam, for the wonderful lecture.
Yeah. Thank you, Dr. Subhash. That was a wonderful talk, as well as your videos were very wonderful. And really, I learned a lot. I'm not a laparoscopic surgeon, but I usually learn from many of you, the youngsters. And I must say that you have covered everything in the endosuturing, like placing the ports, the trocar placements, then the contralateral techniques of various laparoscopic suturing, knots in surgical practice, intracorporeal and extracorporeal, both you have nicely covered. And the various suture materials also you have nicely told that always there is a confusion which suture material to be used. And needles. And I just recently heard about some endoscopy needles.
Thank you, Dr. Malla. She has explained very nicely.
Thank you, sir.
And all in simple language. I think we should have given him more time, Dr. Pratik. Next time,
we'll invite him again, sir. Definitely, sir.
One add to his biodata. He's speaking Marathi very nice.
Yes. He has great coverage of many languages. We have Dr.
Thank
Shubha.
Thank you, Dr. Malla.
Shubha ma'am, would you like to continue your presentation? Are you comfortable? We can't hear you. I think you're muted.
And he has explained very nicely the suturing techniques and material and all that. Even I think we are tempting to do suturings and all those like Malla, Dr. Malla.
Am I audible now?
Yes, ma'am. Please go ahead.
Yes.
Okay, thank you. Yeah, so any implant which cannot be located by the patient should be immediately sought for. And I just wanted to share the imaging techniques which can be used. The currently available implant in the market is on the right hand side, the radio opaque one. It is visible in all four modalities: the X-ray, the ultrasound, the CT scan, and the MRI. And this is how it will look. Well, when we say ultrasound, we need to use the transducer of greater than 10 megahertz frequency, and we need to have a slightly special setting in order to see the device on an end-on experience. That is how it looks in ultrasound. I hope you are able to see here, and it is the acoustic shadow below that. Again, here that is a normally placed implant, the upper picture. The lower photograph, the ultrasound photograph, is showing it inside the biceps muscle. And then that is the acoustic shadow. So I just wanted to bring home a fact here that when Indian women are placed with the implant under the skin of the upper arm, the traditional dress of Indian women is, the sari attire with a jacket, and very often the jacket tightens. And if there is friction at the time of wearing clothes or taking them off, the implant just might get displaced from the subdermal to the intramuscular place, because after insertion of barium sulfate, this particular implant has become a little stiff. So utmost care to be taken that the skin should remain, the implant should remain just under the skin, and women should be advised loose clothing, and also those women who are athletic, especially involved in contact sports like wrestling and kabaddi, etc. In them, actually, a special warning has to be given. And the figure on the right hand side is the MRI picture, where it is placed just inside, just below the surface of the biceps muscle. So that is how the imaging will help us. And if imaging also fails to localize, the serum etonorgestrel levels should be sought for. But the level will only indicate that the implant is present somewhere, but will never confirm the location. So obtain when unable to localize by palpation and imaging techniques, the levels. And the woman should not be, using other contraceptive hormones to avoid cross-reactivity. Assay can only be performed by approved laboratories, and contact the manufacturer for assistance in submitting the sample. So we need to look for the MSD Organon now, the resource people, to help us to get over this problem. This is something very, very rare, and we need not, be unduly worried while providing the service. The indications for removal are at the woman's request, or if there is a medical indication, for example, there is history of new onset risk of thrombosis or endocrine disorder or hypertension, or, she goes on to HIV medication, or she goes on to anti-epileptic drugs, etc., etc. And at the end of 3 years of use, of course, and it should be performed by a trained person with correct instructions. And if the woman desires to continue the same method, a reinsertion can be performed in the same, track of what we have removed. And this very simple tray, and this is the method, and under small dose of local anesthetic, a very small 2 millimeter incision, and it can be retrieved. I will not go over the video because I feel that this will be cannot be accommodated in a talk like this. And how to replace, I have already spoken that anesthetize the insertion site and the insertion canal with a higher dose of anesthetic, and it can be a fresh device can be inserted. So for removal, it should be removed after 3 years, and it is radio opaque, subdermal, 99% effective, does not require daily, weekly, monthly administration, rapid return of normal cycles after removal, and most common side effect is irregular bleeding, and counseling will get us across that bridge. These are some studies which have been shown here, Indian studies, which show very good continuation rates, and with good counseling, they can overcome the side effects which have been shown. And 40% return of ovulation within 1 month of removal, so there is no risk of a delayed return of fertility. This is to conclude that 9 health organizations across the globe have concluded that long-acting reversible contraceptives, including the implanons, are the most effective methods, and have recommended universal access to LARC for all women to be made a priority. So when we talk about universal health care, I think universal access to LARC also should be included in that, and that is what will help us to achieve SDG. And you can see the list of professional societies, which includes FIGO and automatically includes FOXY, therefore, and the WHO, and the FP 2020, which has now become the FP 2030, NICE, the SOGC of Canada, the ACOG, the CDC, and the AAP, that is the American Academy of Pediatrics, also endorsed this, because interval between 2 births is a very important determinant of neonatal, perinatal morbidity and mortality. Promise of LARC in the pandemic, therefore, to conclude, is It is a huge promise. It is a one-time intervention. The follow-up can be telephonic. Menstrual problem can be tackled easily with some small medications given over the telemedicine counter. It is cost-effective because it lasts for 3 years rather than a monthly expense, and it is an external method. The charm of implant is that it offers a woman a device placement which is away from her reproductive tract, and therefore it is easier on the mind of the couple while having sex. Birth control, therefore, is the first important step a woman must take towards the goal of her freedom. We all acknowledge that. It's close to our heart, these kind of statements. And this is the lady Margaret Sanger who first brought pills into the foray for contraception, and she revolutionized the concept of contraception and brought about female autonomy as a very important issue in a male dominated society. It is in fact the first step. Birth control is the first step she must take to be a man's equal, and it is the first step they must both take towards human emancipation. I think that is important, that the couple have to come forward for birth control options rather than the mother alone. Thank you very much for the patient hearing, and thank you, Dr. Pratik Tambe, once again for involving me here. Thank you, Pardesi sir, for your patience. Thanks a lot. Yeah.
Thank you very much, ma'am, for that wonderful talk. And we apologize to the viewers for the interruption in between. There were some technical issues, but madam was kind enough to wait and restart the talk after the other two speakers had finished. We have a few questions which have come in from the audience. Is Dr. Rohan Palshetkar around? Okay, so most of these questions are for Rohan, and the first question is from Dr. Sonal Sarude. She's from Pune, and she's asking what is the role of diet as far as male infertility is concerned. So if Rohan is not around, then I will try and address that particular question. As far as diet is concerned, there is a lot of speculation and there are a lot of theories that the food that we eat, the water that we drink, the air that we breathe are all polluted. There are some chemicals, there are some pesticides, and there are as yet unnamed agents which we are all subject to. And this was touched upon by Rohan during his talk when he talked about the issue of having reactive oxygen species which are in excess. Once the amount of reactive oxygen species in the body exceed whatever is the body's capacity to scavenge these free radicals, then what happens is that it may turn out that you may land up with subfertility, oligoastheno, teratozospermia. That being said, there are some important food items which may help to improve the amount of vitamins and trace elements. If you have a healthy balanced diet, what we call the 5 a day, which is popularized all over the world, that should go to some extent towards counteracting this particular issue. But unfortunately, I'm not really sure whether that is going to go a long way towards curing a patient who already has OAT, and that is where medical treatment is essential. I'm facing some issues with starting my video, so please bear with me. I will have to log out and log back in. The video is now finally functioning. Great. The second question is from one of my teachers, Dr. Satish Kumar Sanjanwala. Thank you so much, sir, for logging in and being part of our event. It's lovely to have you in the audience. And sir is asking, what is the best available treatment for astenosospermia? What is the role of the age-old herbal ingredients in correcting OAT, and can it be given along with our medicines? So that's difficult to comment because we have no standardized randomized controlled trials. Anecdotal evidence does exist that the traditional herbal therapies, the Korean ginseng, and all the other things which are sold over the counter are effective remedies. But unfortunately, since we don't have randomized controlled trials and since we don't have good studies to back up those claims, we can't really talk about those on this particular platform. What I can talk about is the best available treatments today, and the two primary molecules that we usually talk about are number one astaxanthin and number two is coenzyme Q10, the reduced form, also known as ubiquinol. I'll just share my screen. I have a few interesting slides on this particular issue, and just bear with me for a second. Pull up that presentation. I had kept it ready. Yeah. So this is coenzyme Q10, and it's very important as far as the mitochondria or the energy store of the sperm is concerned. There are two different forms. One is the reduced form and one is the non-active form. The reduced form is called as ubiquinol, and that is the one which is supposed to be most potent. And this is often lacking in most patients who have male factor infertility. 90% of the content is present in the reduced form. And you can see that once it is administered, the sperm concentration, density, as well as motility increase significantly. And there are several studies to back up this over several years now, over the past decade or so. You can see that the sperm motility increases significantly, and also the morphology also improves, which helps to increase the fertility and the clinical pregnancy rate. Also, there are other studies which have tried to look at the particular dose which is effective. And this particular study, which was conducted over 6 months, has found that 150 milligrams per day of the reduced form or the active form is the most effective as far as treatment of these patients is concerned. Significantly better sperm counts, motility, as well as fertility. So that's ubiquinol or the active form of coenzyme Q10. And the second of these has already been spoken about by Rohan when he talked about astaxanthin. It's probably the best antioxidant which is known to man, almost 3,000 times more potent than vitamin C and vitamin E. And you can see here in these slides that it's a pure antioxidant and it's available very widely. In fact, in Western countries, it is sold as a nutraceutical. You don't even need a prescription to buy it. You can buy it over the counter. The best dose that is recommended is about 16 milligrams per day for a period of at least 12 weeks, and gives significantly better results as far as the parameters of sperm are concerned, as well as pregnancy is concerned. Fertilization rates and clinical pregnancy rates are significantly higher once you prescribe astaxanthin. So I hope that answers the question, sir. We have one last question, and that is from Dr. Surya Kumari, and she's from Rajamundri, and she's asking, in a child with undescended testes at birth and which is replaced after 4 months, does the child face the problem of infertility in adulthood due to oligospermia or azoospermia? If it is something which is a unilateral undescended testis, then the incidence of infertility in adulthood is significantly lower. On the other hand, if it is a bilateral cryptorchidism, then this is more associated with genetic issues, balanced or unbalanced translocations, and these are, of course, known to be more associated with infertility and other issues later on in life. There are a lot of felicitations and congratulations from all the audience. We have more than 650 viewers logged in from all over the country, not just Mumbai or Maharashtra. And there have been congratulations for all the speakers. One such comment is posted here. Dr. Charu Pratap from Haridwar in Uttaranchal says, very helpful presentation. I think she was referring to Dr. Shobha Gudi, because that particular comment came in when Dr. Shobha ma'am was speaking. So thank you to everyone for a fantastic program.
Thank you,
If
Chairman.
there are no more questions or comments, then I will propose the official vote of thanks. I'd invite Dr. Shobha Gudi ma'am and Dr. Vidya Thobi to please present their closing remarks before we close this event.
I must thank Dr. Pratik Tambe to bring varied topics always on the platform of Amongst Endocrinology. And today we learned 3 best speakers on their various topics. I must say, Dr. Shobha Gudi, always I love to listen to you, to her presentation. And she talked about Implanon very nicely, and she conducts various workshops, and I witness always the flow of thoughts and her whatever the things she present, they're always excellent. About Dr. Subhash, it was really in between I had some net issues, so I could not, and I was traveling to my hospital back. So I could not comment till end, but Dr. Subhash has done various videos on the endo suturing and the demonstration. Those are very excellent videos, and for the learners they are best. How to hold, how much from the length, the suture material, whatever he has presented, that was excellent. And I hope that Corona ends and he conducts his endoscopic committee as a chair. He conducts many workshops for the learners. That is the second thing about that. And the male infertility by Dr. Rohan. It was again ACE presentation, what I say. And the micronutrients, which always we discuss in my committee, food and drug committee, the micronutrients, the role of micronutrients, the oxidative stress, which always is included in the infertility treatment, and evidence-based behind that use of those micronutrients was very nicely told by Dr. Rohan. I must congratulate again and again Dr. Pratik for bringing out various different topics on this platform. And thanks, Amox, for bringing us together again. Thank you very much. Thank you very much.
Thank you. Dr. Shobha ma'am?
Yeah. Pratik, I must congratulate you. When you called me first, I thought that this is going to be about hormones and, so maybe you want something on contraception, but it does look like you have made it very versatile, and different people who have varied interests could listen. And you have that art, actually. I have seen it all throughout. I was a co-chairperson with you in Dr. Nandita's term, and of course, you were so enterprising, amazing. We used to say that Pratik doesn't sleep, or whether he has his food is very doubtful, and there were so many things being conjectured about you. But I think the fundamental thing is that you are very dedicated. You are very, very dedicated to your cause, and you did bring about a lot of change in the way the committee work has to be performed. There was a lot of learning. I think you did 2, at least one I attended, but I think you did 2 in BSOG, 2 subsequent years. And I attended one on the ovary and the ectopic pregnancy and all, and it was really good. And that was the time when the in-person things were happening, and quite a lot of appreciation from BSOG members for your program. So I think that there is a lot of credit in what you have so far done for Foxy and Amox, and I really wish you all the best, Pratik, that you must
Thank you so much.
achieve everything that you have dreamed of. You are very, very enterprising, and as Vidya said, I too learned a lot from you, because we did make a slightly delayed entry into Foxy in contrast to you. So there has been a lot of learning from people younger to us. I too acknowledge it, like Vidya. Thank you, Vidya, for those wonderful, kind words. And I must not reveal now that you're a good friend of mine. Otherwise, people will think that this is out of, our love or friendship. So the fact remains that Vidya did fantastic work as a chairperson. And as she rightly says, today is the last but one day. And it's nice, Vidya, to meet you
Yeah,
on
yeah,
the
yeah.
last but one day of your committee work. And we must
Definitely,
thank
definitely. And we continue to work
Just thank
together.
Pratik for bringing
For
that.
workers,
Of
there is
course.
no end and no
Yes,
beginning.
yes,
What I feel.
Yes,
I
our
always
work
get
never
inspired
ends.
from
It
Dr.
is
Pratik.
only, yeah, it is only a post which changes, that's all.
Yes,
And
yes,
I
yes.
compliment the two young speakers, Rohan and Subhash. And Rohan was, the ever-present factor in Dr. Nandita's year, and we could not imagine Nandita without him being there. And he really has done a lot of good at a very young age, and he has kind of made his mark in this field, in the field of infertility. I wish him all the best. His presentation was very crisp today, no beating around the bush, and he gave a very lucid message. Thank you, Rohan, for that wonderful lecture. And सुभाष क्या कहना सुभाष, अभी तो चेयरपर्सन बने भी नहीं है और इतना अच्छा काम कर रहे हैं. Very nice, very instructive videos. And I think everything that you said about the surgeon's blues about endoscopy was true, because we have experienced all of it. So I wish that you could understand the other aspect of the learning curve, or whatever it is called, for those who have for years done open surgery, and then we have been asked. So it's not exactly like teaching the old horse new tricks, but then of course it was difficult for us. But we don't kind of make very fast progress because we are good vaginal surgeons. Many of my contemporaries share that with me, that, and I agree with them, that we prefer to do the vaginal approach than laparoscopic approach, even for, or we do the LAVH. So that is the reason we don't pick up skills. So till such time, well, maybe it is a little harder for our generation, but we will definitely try. And we were a lot inspired by your talk today, because you made it look very simple, and you brought in ergonomics, which is very important for laparoscopic surgery. You brought in a good amount of ergonomics into it. So I must thank Pratik for giving me this extra chance to speak, because it does matter that we have a higher sense of involvement in any program rather than just giving our talk. So all in all, full marks, 10 out of 10 for you today, and at least from my side. And Pardesi sir, thank you very much for being there for us. Thanks a lot. Thank you, Pratik.
Thank you very much, ma'am. So before we close this meeting, I would just like to propose the official vote of thanks. On behalf of the AMOG's Endocrinology Committee and myself as the chairperson, I'd like to express my gratitude to our esteemed president, Dr. Nandita Palshetkar, our secretary, Dr. Arun Nayak, the three chairpersons for the Foxy Food, Drug, Medico-Surgical Equipment Committee, who are incidentally and coincidentally chairpersons for today's event, Dr. Rajendra Singh Pardeshi, who is now the vice president of AMOG's, Dr. Amir Purandare, who is now the Vice President elect of AMOG's, Dr. Vidya Thobi, ma'am, thank you so much. Despite your poor health, being here right till the very end, we wish you good health and hope you're back on your feet very soon. We hope to see you active very soon again. Three excellent speakers, Dr. Shobha Gudi, who despite the technical issues stayed on till the end and finished her presentation and conveyed the right take-home messages regarding a very novel device, Implanon. Dr. Rohan Palshetkar, who spoke on male infertility and the current management, including medical and surgical treatment. And the icing on the cake was Dr. Subhash Malya, who spoke about laparoscopic endosuturing and showed us a variety of videos. Thank you so much, all of you, for gracing the occasion. I'd like to also express my gratitude to the ICOG chairperson, Dr. Mandakini Meg, and the secretary of ICOG, Dr. Parag Biniwale, for granting us the ICOG credit points. To the Science Integra team, Subbu and Session, thank you so much for being our academic and scientific backbone. And finally, last but not least, the team of Acumentis Viviana, who have been our academic partners for this entire series. Thank you so much for supporting us in this scientific endeavor. We have over 650 delegates logged in for today's event, which is fantastic considering that it's an afternoon event and there are so many other programs happening every day simultaneously with so many legendary stalwarts gracing the occasion in so many of these events. Thank you for coming to our small little event. The ICOG credit point certificate is available at the viewer portal. The download button is usually enabled only after 3 p.m. in the last half an hour of the event. So if you refresh the page, you will see the button. Please click it and you can download your credit point certificate. We look forward to seeing you very soon at the next event. Until then, take care, God bless, and stay safe. Bye for now.
Thank you.
Thank you very much, ma'am. Support, you can take us off air.
Thank you.
Thank you very much. Take care. Bye.
Bye.